All right. This is the Pediatric Subcommittee meeting. I will say, somewhat serendipitously, the one day that the committee before us went long happened to be a good timing because I know for certain we don't have a quorum today, so we can't vote on any resolutions. So I'm going to go ahead and start this meeting beginning at 10:44. This is the Pediatric Subcommittee meeting of GTAC. Roll call. Deb Brown has notified me that she would not be here today. Britt DeVilliers also will not be here. Bonnie is on her way. I just spoke with her, so she is present. Charles Jaquith? Here. Juan Juarez will not be here. Julie? Here. Jorge Sanz? Here. And Sally Snow will not be here. And Vern Walker? Here. All right, so let's start with committee reports. Let me pull up our agenda here. All right, first is Air Medical.
Air Medical will be meeting tomorrow, so I'll send you an email with a report as far as those meeting minutes.
EMS.
I was unable to attend the meeting in November, but I will be attending later this, I believe it's today. It's either today or tomorrow. And I'll have a report.
Education.
Education just met right before our committee meeting. The biggest one that they talked about was moving a motion forward that would require CE programs to have a medical director connected to it. As of right now, you're not required to have a medical director to have a CE program. Several other things they're still working on.
Thank you. Injury prevention. That's one of our absentee liaisons. And medical directors.
They meet after our meeting this afternoon at 1.
Are you working something?
Cover that one.
So I will put you in for a report for next time.
I'll get that to you.
Stroke.
Stroke will meet tomorrow afternoon, so I will get the minutes to you.
Trauma systems.
In Sally's absence, I'll attend that meeting and take notes.
The RAC. Okay, I'll follow up on that one. And disaster planning.
They meet tomorrow at 2:30, I think it is, and I'll cover that one.
Okay, looking from our previous minutes, I don't believe that we had any lingering issues going back to the other committees that were pediatric specific. So that takes us to item number 3, EMS for Children State Partnership Update. And this is Dr. Manish Shah.
Good morning. I'm here on behalf of the Emergency Medical Services for Children State Partnership as the program director. One update that I have is that our program manager, Tony Gilchrist, accepted a position as the EMS program manager for the EMSC program at the National Resource Center in Washington, D.C. And so that's why I'm here instead of him. And we're in the process of selecting a new program manager to fill his position. One update that I wanted to give today is about a tool that we are creating called the Pediatric Pre-Hospital Protocol Resource Tool. Just a brief background on this is that the reason we're creating this is that the Institute of Medicine has recommended that evidence-based guidelines for pre-hospital care be developed for treatment, triage, and transport of patients, including pediatric patients. And on a national level, the National Highway Traffic Safety Administration has funded the Federal Interagency Council on EMS and the National EMS Advisory Council to create a national evidence-based guideline model process, which has been published in Academic Emergency Medicine this past year by Eddie Lang. So this process has been defined now and is in place, and I know you can't see all the details here, but what it involves is gathering input from the EMS system to identify what are the needs that need to be addressed in terms of developing evidence-based guidelines for care, establishing priorities for that, and then actually developing them using evidence-based guideline methodology, and then creating guidelines with stakeholder input, disseminating those guidelines, implementing them, and then evaluating them from a quality improvement and effectiveness standpoint. This process has actually started on a national level. EMSC has collaborated with the National Highway Traffic Safety Administration to create 3 evidence-based guidelines using this process. One is on pediatric seizure management in the pre-hospital setting. Another's on pain management, and this is not specific to pediatrics, it's for all patients of all ages. And then the use of helicopter EMS. These 3 that have been created are in the process of being submitted for publication to pre-hospital emergency care, and they are supposed to be published. It's expected that they will be published in the September issue of Pre-Hospital Emergency Care as a group, including a paper on the methodology used using the National Evidence-Based Guideline Model process. Tying into that, I have a Emergency Medical Services for Children Targeted Issues grant that Tony Gilchrist has mentioned in the past to use the same process to create a pediatric respiratory distress protocol. We have created that, and that addresses the care of children when it comes to presumed bronchiolitis, croup, and asthma. And we have now implemented this protocol in the Houston Fire Department EMS system, City of Austin, Travis County EMS, and Biotel EMS in Dallas. We're currently collecting data on post-implementation impact, both from the EMS side and also from the major children's hospitals in all 3 cities. And so this will be available soon online, and it will be available on a new portal that we're creating on our EMSC website that I wanted to share with you. And once all of these 3, the first 3 are published, those 2 will be referenced as resources on our website as well. So as I mentioned, the first 3 are anticipated to be published in September, and then here's our website. So these will probably be available in the next few weeks. We're just working out the last few programming issues so that it can go live later on in March. So here is what our homepage looks like. And so you'll see here under resources, Pediatric Pre-Hospital Protocol Resources listed as the first resource. So under that, once you click on that, there will be the following available. We're going to have evidence-based pediatric protocols, evidence-based pediatric summaries, and links to existing resources. So what are each of these things? The first one is when it comes to a full guideline or protocol, those are ones where sufficient literature exists to create a full guideline. And so the pediatric respiratory distress guideline that we created and have implemented in those 3 cities, that will be posted there later on in March. When it comes to the pediatric summaries, in the past, our EMSC state partnership has informed this group about the creation of summaries when not enough evidence is available to actually create a full guideline, but there's enough information to potentially address controversial issues or management questions. And so we have done that now for cervical spine immobilization in children, for management of non-traumatic shock, post-resuscitation care in children, including addressing the issue of therapeutic hypothermia and the issue of non-transport. These 4 will also be posted on the website when it goes live. And then finally, links to existing resources. So once those other 3 are published by the NHTSA EMSC work group, references to those publications will be listed under resources, as well as other upcoming resources when they're made available. And so our purpose in creating this is in response to stakeholder feedback. We've received feedback from this committee and also from the Medical Directors Committee that EMS agencies would like guidance from the pediatric experts in our state on creation or revision of guidelines. And so this resource is intended to allow agencies to customize their protocols and with consideration of what resources they have available, the training that their providers have, because each agency may have different levels of providers and scope of practice, and then also allow consideration for what availability there is for each agency in terms of online medical direction, geographic considerations in terms of rural versus urban, and what your call volumes are. And so this is not intended to be a guideline where you implement it as is, but it's recommended that it's be used as a summary of evidence with a proposed algorithm for care when a full protocol is created with customization based on these considerations here. And so it's not meant to be a substitute for clinical judgment, and it's not applicable to all patient encounters or situations. And so I summarized.
Dr. Shaw,
Yes.
are those disclaimers on the protocols themselves?
Yes. On the home page for the tool, we have noted that disclaimer. Yes. So I described the evidence summaries a moment ago, so I won't go into that again. But here are the list of the topics that I had just mentioned in terms of the evidence summaries that we will post on that website. And just to clarify the process that we used when we created the Pediatric Respiratory Distress Protocol, we collaborated with the Texas Children's Hospital Evidence-Based Outcome Center to draft the summaries that we created, and that anytime we make a recommendation, we note what the evidence quality is for that recommendation using a 4-level system, strong, moderate, low, or very low, and then we also recommend the strength of that recommendation as either strong or weak based on the evidence available. When I mentioned that there will be future resources posted on the website as well, one of these future resources ties in nicely with an ongoing project that I'm participating in with the National Association of State EMS Officials. They've received funding from NHTSA to create model EMS guidelines for patients of all ages, and that pediatric needs will be integrated into each guideline that's created. And so the timeline on this it's anticipated to be finished in the summer of 2014. And there are some pediatric implications to this. Some things that have come up in our work group are things that have been brought up by this committee before and other committees of GTAC, including how does one define what a pediatric patient is, what's the age cutoff, and so we're attempting to address that as part of this NSEMSO work group. One question that came up was, should the guidelines be created for pediatric patients separate from adult guidelines? Our decision on that is that each guideline should have pediatric recommendations side by side with what the adult guidelines for care for that situation should be, unless it's a pediatric specific situation such as neonatal resuscitation, which wouldn't apply to an adult. And so it is nice that the American Academy of Pediatrics does have pediatric representation with me and Brian Moore, who's the the New Mexico State Medical Director and also an AAP member and pediatric emergency medicine physician. We're the 2 pediatric representatives on this project. So as I mentioned, these will be done in August of 2014, and we will post that as a reference as well on our Texas EMSC State Partnership website. So before I go on to other updates, are there questions about just the protocol resource tool?
just quick question, I think this is a great first step, to move on to standardization of care delivered to children, on the pre-hospitalized setting. But are there any strategies or tools that are going to follow up with these as far as, attachment to guidelines or PI or quality metrics to see, how those guidelines were implemented as time goes by?
So for the respiratory distress protocol, that is being studied in terms of actual outcomes. In terms of the pain management one that was created with NHTSA and EMSC collaboration, that one's actually being studied in several states in terms of barriers and enablers to statewide uptake by individual EMS agencies within the state. So those things will be, at least for those two guidelines, will be addressed.
Thanks.
Other questions about the tool? No? Okay. So I'll just give a few brief updates then about some other things that we're working on. One is the National Pediatric Readiness Project. This is a nationwide initiative endorsed by the American Academy of Pediatrics, American College of Emergency Physicians, Emergency Nurses Association, and the EMSC program. And in Texas, it's also endorsed by the Children's Hospital Association of Texas, Texas Pediatric Society, and the Texas Hospital Association to assess readiness of emergency departments in our state for caring for pediatric patients. We're in the process of collecting data in Texas for this. Our window opened at the beginning of January. It closes at the end of March. We currently have had a response of about 32% of the hospitals in the state, and we're hoping to achieve an 80% response rate in this next month. So what we plan to do with that information is that as a state partnership, we plan to use that data to identify potential needs for quality improvement on a statewide level. And so where we will need your help in the future and other help of stakeholders that attend the GTAC meeting is in receiving feedback on how to best integrate quality improvement metrics for the needs of children as we look at the data that we receive from the hospitals.
Dr. Shaw, in the past this group has been very active in personally looking in our own backyards and helping to facilitate responses. Mm-hmm. Is that a possibility for this particular project?
Yes, that would be helpful as well. And so I have a list of all the hospitals across the state that have either responded, not responded, or have started the assessment but haven't finished it. And so I can disseminate that to you, and then if you wanted to disseminate it to the rest of the committee. We're now in the phase, since it's the last month of the assessment, where personal phone calls to the hospitals are now the most effective tool to help ensure responses.
And when is that deadline?
March 31st.
Okay.
Yeah.
So then can we say by next Friday we'll receive our assignments?
Yes.
And that includes the people who are absent, so they get double assignments?
Yes. Exactly. Another update for all of you is on ambulance equipment. In the past, we have discussed with this committee about the nationally endorsed ambulance equipment list endorsed by the AAP, ACEP, National Association of EMS Physicians, NASEMSO, and the EMSC program, and the American College of Surgeons. This list usually gets revised every 3 years. It is up for revision, and I'm actually the AAP's representative to help revise it. I'd like to share that the feedback that we have received from the GTAC committees, not just the Pediatrics Committee, but several of the other committees with whom we've shared this information after our last statewide assessment, has been valuable so that we can go back on a national level and make sure that the needs of our stakeholders are represented. So, for example, some of the feedback that we've received that should be integrated into the new ambulance equipment list is the removal of things that are not supported by evidence, such as having a meconium aspirator on ambulances, removing things that are not in the scope of practice for providers, and so allowing for individualization at the agency level. So if, for example, an agency does not allow its providers to intubate, then they should not be required to carry intubation equipment. Removal of things that potentially cause harm, such as traction splints. And we've also advocated that pieces of equipment that aren't within the scope of practice or are not routinely used by a certain provider level be moved to the appropriate list. So for example, a length-based tape has medications and equipment that are often not used by a BLS provider, and so we recommended that that be moved to the ALS list rather than the BLS list. So I'd like to reemphasize that the feedback that we've received from folks in the state of Texas has been represented nationally, and we thank you for your feedback because that's been very helpful. And although we're not a state that adopts this list, I think that it's still useful to get feedback from stakeholders in this state because there are other states like ours that don't adopt the list, and there are implications even for states who do. And so I think that the stakeholder feedback that we've received will have an impact on states out beyond Texas. So we thank you again for the feedback you've given.
So in other states that have not adopted the list as a required list, is there some measure of how it's guided different agencies?
I don't have information on that. Some recommend it, but it's not required. But I don't have data on which states do that or any metrics related to that. And then my last update is, as a segue, since I mentioned the ambulance equipment, we are due to do another assessment on a statewide level again of equipment available on our ambulances and the availability of online and offline medical direction. And so we'll be doing this in 2013 and in 2015. So the assessment for 2013 will go from July through the end of September of 2013. So our need for you and the stakeholders in the room is that we're in the process of updating our database of EMS agencies with accurate contact information. So when we get in touch with you, if you receive a letter in the mail or you receive a phone call from us, please respond, and then we would absolutely encourage your participation in the assessment this summer as well to complete that, because as I mentioned before, the data that we receive from those assessments helps guide the EMSC program in terms of identifying what are needs in the state for children and where do we need to target our efforts. So that is all that I have for updates from the EMSC state partnership. Any questions for me? No?
Thank you.
Okay, thank you.
All right, agenda item number 4, State Child Fatality Review Team Update.
Hi, nice to see you. My name is Susan Rodriguez, and I'm the DSHS Coordinator of Child Fatality Review, and I'm here on behalf of the state. I'm here on behalf of the state committee. Is that better? The State Child Fatality Review Team Committee. I want to give you several updates about things that are going on with Child Fatality Review. We have completed the 2012 annual report on child fatality review in Texas, and it's in the review process and will be sent to the governor, legislators, and released to the public on April 1st. There were some really significant things that I'd like to highlight with you that I think would be of interest to the Pediatric Committee. Sure, thank you. Is that better? Oh my God, I feel so silly. I feel like I'm kissing the mic. Okay. Oh, yay. And I want you to hear me. I have interesting things to say. I do want to say that we have currently right now in 2012, we had 69 teams operating throughout Texas, covering 193 of the 254 counties. One of the goals of the state committee has always been to have 100% coverage, and we continue to work toward that goal. 93.7% of all Texas children live in a community where child deaths are reviewed and where there are multidisciplinary teams looking at how they can prevent future deaths. We do retrospective reviews, so in 2012, the teams that reviewed child deaths in their community were looking at the 2010 deaths. And what we found in 2010, in those deaths, child deaths that occurred in 2010, is that there was a significant decrease in child deaths from the prior year. Wow, this is something to get really excited about. In 2009, there were 4,002 children that died in Texas. And in
Sorry, can you repeat that number?
4,002. In 2010, there were 3,795. So it's statistically significant, the decline in death. So we wanted to look at, oh gosh, what is this, is there some sort of pattern? What was this due to? Are there particular kind of deaths that we saw the decline in? So we did trend analysis over 6 years to look at what was happening to see if we could isolate particular kind of deaths that we're seeing the decline in. And what we did, we're able to see through the trend analysis is that we had a decline in natural deaths and in accidental deaths when you look at manner. So natural and accidental. So then we looked even deeper to see what happened. And the decline in natural deaths was isolated to kids 5 and over. And this was a little discouraging to us, but at DSHS we've been working for a couple of years on an infant mortality project trying to bring down deaths of infants. So we were really hopeful at first when we saw this decline. We thought, oh, maybe it's about infant mortality, but it's kids over 5 where we see the natural death decline. Then the decline in accidental deaths was isolated within 2 age ranges of children 1 to 4 and children 15 to 17. And there were very specific mechanisms that we saw with those different groups. In the kids 1 to 4, where we saw that decline, there was a substantial decline in the drowning death rate. And that was very encouraging because we've done a lot of work in child fatality review teams focusing on drowning prevention and water safety. In the 15 to 17 year range, we saw a substantial decline in motor vehicle crash deaths. So this is good news all around. Another thing that we've really focused on.
Can you tell us what those decreases in rates were? Do you have those rates
I didn't
available?
bring that with me. I'm sorry, I should have. I'd be glad to send it to you. Okay. So this is really good news, and we're really excited to see if these declines continue in the next year. Something else I wanted to report about the annual report. The State Child Fatality Review Team Committee is required by law every year to submit recommendations to the governor, the legislators, and to the public. And I wanted to tell you to kind of focus on what the big recommendations are that they're putting forward this year. Once again, these are kind of repetitive if you remember from past years. Ban on wireless communication devices while driving. A repeal of parent-taught driver education. They want to make it an offense if you're operating a motor vehicle and you have a detectable amount of alcohol and you have a child in the car. That's not a law right now. Another law that they're looking at is that they're really proposing and recommending is that all new residential swimming pools be required to have 4-sided fencing to limit access to pools. Where the drowning deaths that we do see, the great preponderance are focused on residential pools. So that's something else. And then April as Water Safety Month. Y'all may know or not know that nationally May is recognized as Water Safety Month. But because of our climate and because of pools opening as early as April, where we really want to jump in there ahead of time. The good news is that these recommendations, even though they've been repeated the last couple of years, and I feel very strongly about them, is that two of the recommendations, one of which I'll explain in a minute, the recommendation about Water Safety Month, that April be recognized as Water Safety Month, has been sponsored by Senator Jane Nelson. There's a resolution that has been filed, and there is a lot of support. There will be a hearing. It has not had a Senate committee hearing yet, but there will be a hearing upcoming probably in April. And we've been asked by Senator Nelson's office to have a big presence there of people who are interested in drowning prevention and water safety. And when I have more details about that hearing, I'd be glad to send that to you if you would send to your membership to see if we can rally the troops and have a presence there.
So one of the things that we've discussed in previous years' meetings has been the positive data with drownings, and with this report, how have changes in the availability of data specific to areas, geocoded areas affected the report? Are there specific areas in the country that you can ascribe big changes in mortality to good best practices and strategies that we could replicate throughout the state?
As far as national trends, I'm not as familiar with. Texas, Florida, California, we're always lumped together as really having the highest rates, and that's because we have the larger coastal areas, and we also have a lot of bodies of water.
Well, I was referring to within the state.
Oh, within the state? I'm sorry, if you could repeat your question.
So my question was, do we now have enough robust data, because we've spent a couple of years talking about how we would collect such data and what happens to that data when in the past it had been going to the Texas Department of State Health Services. Do we now have the availability of data and the reporting in such a way that we can look at areas of the state to see what is successful and what isn't successful?
One of the challenges that we have, there is, of course, the drowning registry that DSHS sponsors, and that all depends upon independent reporting, if things get reported or not. One of the challenges with getting more data is, as I said earlier, we only have child fatality review teams in 193 counties. We don't cover the whole state. And another issue that we have, and we work on this continuously, is to get first responders and dusting investigators to collect more information at the scene of the death. And I know that the drownings that are reviewed by the teams, oftentimes a lot of information was not collected, that critical information about access, if there was any sort of fence, if there was a gate, those kind of things. So we're continuing to work on that. I think we're making a lot of strides, but it's not perfect, and it's not complete.
Yeah, and I think the overall picture, if you're increasing the number of sites that have child fatality review teams at the same time that you're seeing a decreased number of deaths, that really suggests you're really making powerful changes.
I would like to think so. Okay, thank you. The other bill that I wanted to mention to you that I think is of a special interest to this committee and to GTAC in general is that for several sessions in a row, the state committee has recommended that there be some additions to the required state committee in terms of the disciplines. Ever since the statute was created in 1995, there's a long list of disciplines that are required to be on that state committee, but there was a couple of glaring absences, and one is EMS, and the other is family violence. And Senator Nelson has put forward Senate Bill 66, which is now going to add that, hopefully, if it goes through. It was approved unanimously in Senate committee, hasn't gone to House yet, but Senate Bill 66 proposes that EMS be added, as well as a family service or a family violence provider or advocate be added to the picture, add to that professional expertise of the multidisciplinary team.
And that is at each of the CRFT sites or just at the state level?
This is at the state level, that it will be required by law that we have someone on the state committee. In the local teams, I have always recommended to them, they have a little more leeway in terms of who they include in their teams, and many of the local teams already have EMS involved and domestic violence providers as well. But it'll be good to have that expertise on the state committee, because they work so much on recommendations and in changes in processes and policies within agencies. Okay?
So just my suggestion would certainly be that I would hope that there would be an ongoing communication if that were approved and there were positions with our EMS state partnership and
most definitely
this committee.
Yeah, because we'll be looking for someone at a very high level that can come to that team and work with them. What else did I want to tell you? So both of those bills are important. I'll let you know about the water safety resolution as well as Senate Bill 66. Also, Senate Bill 66 would change our annual report to a biennial report, which, is just a better way to do business. and it will be synced with legislative sessions so that we would have a report that was presented to them the year prior to sessions, so we have time to work on it through the advocacy committee and work with legislators. The other thing I want to tell you, it's coming up just as an FYI, we're partnering for the second time in a row with Prevent Child Abuse Texas to have an annual conference, and that starts on Sunday. And we're expecting to have 800 people there, and there'll be a lot of information and focus on child fatality review as well. Lastly, this is a corollary to the state committee. One of the issues that all of the teams and the state committee deal with a lot is infant mortality, in particular deaths to infants in sleep environments. We see a lot of that. The teams review a lot of that. And Texas is part of a 14-state learning collaborative that's focused on infant mortality, and there are several of us that are assigned to the group that's working on safe sleep, to looking at standardizing messaging and doing some really focused activities around safe sleep for children. And I'm part of that, and it's a great opportunity.
And is that intended to push through professional societies, through hospitals, through consumers?
You know what? We'll partner with whoever. Yeah. I think that's... Oh, the last thing I want to say, as part of that learning collaborative, one of the initiatives that Texas is doing is that there will be a public health grand rounds on March 27th. And when I have the particulars about that, because it will be webcast, I'll send that to you as well, Dr. Macias. Yeah.
Well, as always, thank you so much for your report. You guys are doing great stuff.
Thanks so much.
I have one
Yes,
question. Do you have the data relevant to child abuse as far as, what that subset, or do you remember, what happened to that subset of child abuse deaths or abusive head trauma related days from 2010 to 2009?
No, I don't have that with me, but I'd be glad to look for that and send that to you.
It seems to me, and this is just anecdotal, that we've been seeing more and more and more of those kind of death-related issues for younger
Right.
children.
Mm-hmm.
And the reason why I say that is because now I'm getting subpoenaed on a weekly basis
Yeah.
to go to court on those unfortunate cases. And the other thing that we have, at least in our location, seen a lot of is ATV-related injuries, for children as young as 3 years of age.
Right.
And so
That's very frightening, isn't it? Yeah, the teams review a lot of those ATV-related injuries and deaths. And especially, I don't know where you're from.
El Paso.
El Paso, okay. In East Texas, there are a lot of initiatives going on they're partnering with Texas Parks and Wildlife to make it part of hunter education and doing focus groups throughout several counties in East Texas, because that's where we see statewide the highest rate of death with ATVs. With regards to the homicides, the child abuse homicides, there I do know, and I apologize, I didn't bring the report with me, I should have. I do know that there is an increase in child abuse homicides. And whether I can break it down as far as abusive head trauma, a lot of, I don't have that information with me. But what we do see, the kids who are most at risk for the child abuse homicides are the infants.
Mm-hmm.
Yeah.
the interesting part of that subset is that somewhere along the line, and I have said this many, many times, it represents a choice. It doesn't represent so much of an accident or something that goes beyond somebody's, sometimes either per judgment, but that one represents a choice. So somewhere along the line, the
Right.
perpetrator, perform a choice, and he or she choose to do that harm. So
Right.
it seems to me that we should target our efforts to make sure
Right.
that we move into a society that had very little tolerance for that.
Right. I do want to note that there was a federal legislation that was passed at the end of the year and signed into law, creating a commission on child abuse fatalities and how to reduce those. And you may have seen that or heard something about that. Interestingly, just last week, there was a bill filed in the Texas House by Donna Dukes, and it's House Bill 1633, that is asking to create a similar sort of commission on understanding and eliminating child abuse fatalities. And they're looking at very much at like a model like Child Fatality Review, where it's a multidisciplinary membership. The members will be appointed by the governor, by the Speaker of the House, different people. So, it's just been introduced last week. It very much mirrors what was passed federally. Whether it comes to be, would be a good thing, because Texas really does have an alarming rate of child abuse fatalities.
Thank you, Ms. Rodriguez. I was wondering if you could send us the link to the annual report as our charge. I'll ask each of the committee members to review the report, and
Sure.
And if we can talk specifically about the 14-state learning collaborative and infant mortality at our next session with some data, as well as looking at the drowning data, since that has been an issue that has recurred for the past couple of years. That would be wonderful.
Thank you very much. I'm glad to have a specific charge. Thank you.
All right, next issue, next agenda item is pediatric imaging implementation strategies. Just as a reminder, in our previous meetings, we created a position statement for the role of imaging because this was a particularly sensitive issue to pediatrics. Clearly, ionizing radiation has a significant impact on childhood leukemias and childhood cancer deaths. And as part of that position statement that was endorsed by GTAC, we had really five recommendations. One, that all CT scans on children should be performed using pediatric dose reduction protocols, and that those pediatric protocols were available through the Alliance for Radiation Safety and Pediatric Imaging. Two, that imaging modalities that do not use ionizing radiation should be used when feasible, example being ultrasound instead of CT to evaluate for appendicitis. Three, that the avoidance of the use of protocols which automatically result in the performance of multiple CT scans, head, cervical spine, chest, abdomen, and pelvis, in pediatric trauma patients be endorsed. And that number four, that one should avoid further CT imaging once the decision to transfer to definitive care is made, unless the accepting institution specifically requests a scan prior to transfer. If CT imaging is performed prior to transfer, the final radiology report should be included in the patient's transfer documents. And we had coupled that in the subsequent recommendation, which was that the accepting institution should avoid repeating scans, with the encouragement of virtual-based registries, cloud-based abilities to read CTs and see actual images. One of the elements that we had talked about, and I frequently think of the component of knowledge translation as the book that's never read, is that these recommendations sitting without any implementation really do no value in improving quality. And so what we had decided in this group was that during this session we would talk about potential strategies where we could help that implementation process. So I know that we are missing several people from our group, but I wanted to have an open discussion about how we might approach taking our position statement and helping change. And I really see change in several areas. One, in pediatric EDs. Two, in community EDs that often transfer their patients. And three, in pre-hospital settings in transfer settings for agencies that transfer patients between hospitals, where they could help endorse these philosophies. So your thoughts on how we might talk about implementation? And we'd like to leave this open to the audience as well.
Oh, that's a tough one. I really think, Charles, it really applies to an open discussion, through at the beginning, at least in our backyards to see how best we're going to be able to achieve that and and drive forward. Um, One of the things that, at least in our locality, that we don't have is availability for a specific pediatric trained radiology staff. So in our hospital, we do have that, but in our community that we serve, towards, probably about 100 and some plus miles, we see a lot of exams, being done, so it's really difficult, for us sometimes to avoid or to have a strategy to avoid those exams to actually be done without having that consultation, for pediatric radiology services. And, that probably is a specific problem that we have in our entity, but I'm sure that other localities throughout the state probably face the same thing.
Well, and I think that's part of the expectation of our healthcare system. What do we set for expectations when we know that a higher level of care, when a transfer will exist to a higher level of care? What, as part of our recommendation, we recommend against obtaining additional ionizing radiation in diagnostic testing. But the whole question is, how do you change a culture to endorse that concept that you don't have to do that additional CT prior to transfer? But I think taking the suggestion you just made, looking at our own backyards, I would define that backyard multifold. I would think that professional societies like Texas Pediatric Society is a place for us to start. I think the Texas Medical Association is another place to start. I believe the Children's Hospital Association of Texas could help endorse that. Other professional societies or organizations that we could begin discourse with.
Radiology societies. I think, because it's even though the ordering clinician is going to be driving it, it also could generate an educated discussion on the other end, like, hey, do we really need to get this? I know where the patient is going. We can discuss with the clinicians there and maybe hold off because we don't have the ability to reduce the radiation, and it's, that type of.
I think the ACS actually has done a very good job, passing on that message through ATLS.
Right.
So I'm an ETLS instructor, so every time that we meet, and, we actually outreach, to a lot of emergency room physicians, family physicians, or anybody that participates in the delivery of trauma care